The other thing that they will do is they will put a pregnancy category in the literature, whether that's your little handouts, um, or if you're looking it up on the website, they'll have a pregnancy letter on there. Um, this classification is ABCDX. So anytime you see an X, definitely do not give that to your pregnant patient. Your A is your controlled substance in women fail to demonstrate a risk to the fetus in the first trimester, and the possibility of fetal harm appears remote. So, no real evidence in that first trimester or even in later trimesters. So, this is your most benign. We don't see anything wrong with this medication during pregnancy. Our B's go in either animal reproduction studies have not demonstrated a fetal risk, but there are no controlled studies in pregnant women, or animal reproduction studies have shown an adverse effect that was not confirmed in controlled studies in women in the first trimester. So we saw it in the animals, but we didn't see it in the women. So a little bit of a discrepancy there, but they make it a B. But we don't, may not have a big group to say, hey, but maybe one of those we want to watch, or at least maybe we don't want to take it all the time. C's. Either studies in animals have revealed adverse effects on the fetus, and there are no controlled studies in women, or studies in women and animals are not available. So drugs should be given only if the potential benefit justifies the potential risk to the fetus. So with these, a lot of our medications fall in this C category. We just don't know. We don't know if it's going to affect this baby. But, if you just put mama through a traumatic event, she's just, been injected out of the back of a pickup truck. I did have that one. She was 6 months pregnant. Do I want to give her something? Well, if I give her a fentanyl or morphine, then I do have that potential of depressing my baby. Fortunately, as long as we could keep her still, she was pretty good. But she did have a pelvic fracture. I'm sitting here, I'm like, you're 6 months pregnant, you've got a pelvic fracture. And I'm like, what are we going to do? I mean, there's no way you're going to be able to deliver this baby. But the baby had good fetal heart tones, that kind of stuff. So take care of mama, you take care of baby. And that's what it boils down to. I've got to take care of this mama. And then we'll go from there. So oxygenate. Then we get into our D category. So there is positive evidence of human fetal risk, but the benefit from use in pregnant women may be acceptable despite the risk. So if a drug is needed for a life-threatening situation or for a serious disease for which safer drugs cannot be used, then I've got to give her something. These, we carry our midazolam or our diazepam. So for our seizure patients, if it's not that eclamptic seizure and she has a seizure history and I've got to stop her seizure, so obviously take care of her, do all your other things, take care of her airway, get her IV, and then let's give her some midazolam, diazepam, whatever you can do to try to stop the seizure. Those medications are your D category pregnancy. But if I don't take care of mama and get this stopped, I'm going to lose the baby. And then our X, the studies in animals or humans have demonstrated fetal abnormalities. There is evidence of fetal risk based on human experiences or both. And the risk of the drug in the pregnant woman clearly outweighs any possible benefit. So our pregnancy, then we have lactation. So pregnancy is pregnancy exposed registry, risk summary, clinical considerations, and data. Our lactation, including our nursing mothers. That's that risk summary, looking at clinical considerations and then looking at the data. And then female and male users with reproductive potential. So pregnancy testing, contraception, and fertility. So drug categories, looking at medications that can affect the reproductive system. So if I'm already in my late 30s, early 40s, and I know I want to have kids, but I know that this medication can either prevent that or make it more complicated, then that might be a medication I may not want to take. We usually don't have to deal with those just because of the fact I'm just giving it in pre-hospital. I'm giving it really quick, but this is more for your long-term patients. So if you ever went on into nursing, PA, physician, you're going to have to think about those things. So, with medications, some of them will go over the placental barriers. And then lactation, some of them go over into the milk. Some do not. So it just depends on the medication, and you've got to read the material just to learn which ones do and which ones don't. And if you're not sure, look it up. It's fine. That's what we've got Google for. Or we have lots of resources for.